Good morning, everyone, and welcome to week 2, Contemporary Issues in Public Health. Today I'm just going to be giving you a short lecture on limitations of big data. So this week the folders in your online learning materials have canvassed a few different aspects of big data and how this can really guide interventions within contemporary public health issues. And we're just going to recap a little bit on big data and then go into some of the limitations that it has. So basically when we're talking about big data, we're really looking at electronic data sets, electronic quantitative data sets of a ginormous capacity. This has allowed for all sorts of amazing analysis in the public health and health arena, and a lot of explanations and answers for things ready at our fingertips with these large electronic data sets. They're primarily collected through electronic medical records, or EMR. Basically, as the whole health system is digitalised, every point of contact that a patient has with that health service is a data point on a data set. When they've come to the doctor, what they've come to the doctor to see, they come for a pathology test, what the pathology results, what scans they're receiving, what cancer treatment, all of this forms these very big data warehouses or big data sets for us to explore. And like I said, it's that point that the patient touches the healthcare system right from the beginning through the end, and in a lifetime it can be right from your birth through all your immunisations in your childhood, any accidents or emergency presentations you might have, through to your ageing and cancer diagnosis, chronic disease management. You become many, many data points on these large data sets for us to explore as health professionals, particularly in public health. It's estimated in the US that by 2020 there's going to be 25,000 petabytes. Now, a petabyte is 10 to the power of 21 gigabytes. So that's just an unfathomable size, huge size of data that is continuing to increase as populations grow and as we tend to increase our access often to healthcare systems. These records are just going to grow and grow and grow. To give you a sort of visual concept of how big that is in terms of data, we're looking at about 500 billion four-drawer drying cabinets of paper records. So what we used to be very limited in terms of a single patient has a record and it's contained in papers in huge data or medical record warehouses within hospitals. This is now expanded to be accessible by all and obviously not held in paper form anymore. So like I said, a huge plethora of information that as public health professionals we can really start to use to benefit the health of individuals and for protective benefits within public health as well. So particularly it's had some breaking edge benefits for public health, particularly around the spread of epidemics. Okay, so we used to be able to only see one presentation of what might be an outbreak. Say, let's look at Zika virus. So the symptoms for Zika virus can often also mirror dengue symptoms at the initial stage. So what happened in the start of the Zika outbreak in 2014-2015 was that presentations of individuals at different healthcare points, it was just thought to be dengue. But then as they continued to increase in presentation with the same symptoms, they weren't just being treated individually in these systems, it was starting to be monitored within Brazil, in their public health systems because of these data sets, and it was suddenly started to ring alarm bells for public health practitioners saying, we're not sure if this is dengue, let's have a look at what it's doing. And this then led to more of an explanation and then the discovery that it was actually Zika. So we could then also use these data sets to not only track within Brazil, but then track the point of contact that patients going from Brazil to the US had and globally. So big data really has an important role to play in curbing the spread of global epidemics. You can also detect them far earlier. So again, it might not be something like Zika, vector-borne spread, but also just within communicable diseases within the healthcare system. So looking at resistant MRSA and resistant strains of Staphylococcus within the hospital system, we're able to detect these earlier, not just within the one hospital, but within many hospitals across the country, partly because once that patient is registered on the system, that is then got an alert on it, and it's tracked across the different points of contact they have with the healthcare systems, and we're able to, as public health practitioners, curb the spread earlier. Another really important benefit for public health is really looking at that interconnected care. So looking at health service and interconnected care to help with presentation to hospitals. If someone presents to A&E here with heart issues, what is their history? And big data provides that, EMR, medical records provide that. And looking at, okay, so they might present to 3 different or 4 different hospitals over a time period. Let's look at what their management was within that time period and what we could be doing better in the management of, say, their type 2 diabetes or their cardiovascular disease, and prevent them from needing to present to A&E more often. So again, not only does it look at that preventative in terms of spreading and tracking and monitoring disease, but it also can look at the care experienced by individuals. And another fun aspect, I suppose, if you could look at it as being fun, or I think for many public health practitioners it is fun, because big data allows us to conduct RCTs without actually causing human harm. So we can basically take all these hypothetical RCTs that we would love to replicate in a population, but it's just simply unethical, like tracking birth defects with Zika, people that have been exposed to Zika. You're not going to conduct an RCT within the population surrounding this issue, but with this big data, we could hypothetically construct an RCT with populations that haven't been exposed and populations that have been exposed, and then looking at what outcomes are. So it allows us to, again, really look at health issues, and often issues within populations that are too hard to actually examine in real time, but still collect important causative information. So that's looking at it from a global perspective and also from a health service point of view. I thought I might just show you how big data is even impacting on you as students here at Western Sydney. How are we even using it just here within our neighbourhood? So basically, how is big data used at Western Sydney Uni? Well, I've been part of a study run by Professor Andrew Page, looking at called the Wellbeing Study. I'm not sure if you've had contact with this, but it's about using an app. And it's important to remember that big data is not only collected through big medical systems, but also through apps, and your Fitbits and all those sorts of information about movement is also collecting data into warehouses that we can use. So this is an app called Ethica that collected a whole lot of movement, how much you were moving, where you were moving, what your social interactions were, what apps you were looking at. And it is a way of measuring your social, physical and mental well-being. We were then looking at taking this information and adding it to more data, then linking it up with different aspects of life at uni, looking at your outcomes, where you might have fallen down in your grades, what time it might have been at uni, when you were more stressed, all to improve your learning experience. So looking at when students are most vulnerable, how can we improve those support periods for students and then allow them to receive better grades. And this is all through the use of big data, or data collected via the app, and then through databases within the university, such as your marks and points of contact you've had with different services. That's just a little example of how big data is not only being used, within the health industry, globally and nationally, on a public health scale, but also on a local level within our own environment. However, as wonderful as big data is, it does come with several limitations. And that's what I just wanted to really sort of look at with you today and focus on, because it's important to know that there's caveats and limitations to what you're going to be looking at, or where, if you're starting to develop policy intervention in these areas directed by this information, it's important to consider these. So when you've got a massive data set with huge amount of data variables and points, it's very easy to find causation. Okay, statistically significant numbers, you've got the big numbers of data points there to find statistically significant causation. However, it's important to remember if they are or are not true associations, and just look at what confounders may be within that data set, and also test for these and allow for these when you're running your analysis. So really adjust for confounders and also look at if it is a true association. To do this, you really need to pinpoint your question when you're dealing with big data. Don't just think of it as a big lolly shop. You can go in and pick whatever you want. You need to really think about, what am I trying to find, and is this a true association? Otherwise, the information can be quite damaging. If we say, yes, there is association between statin use and diabetes, but it was just an accidental association, we don't want to start putting money into the fact that, and pulling back the use of statins in this population with other detrimental effects. So it's important to really look at your research question, or look at your intervention question, before you can actually determine if it's a true association. Big numbers, probability, statistics mean that you can just have a chance finding, and it's important to be mindful of this as well. Continue to put in place restrictions and adjustment in your statistical analysis for this, because big numbers do result in that 1% probability of chance. So when you're looking at health issues, it's important to remember this as well. Privacy. So you've got all this information on individuals that are collected, often mandatory at time, without their knowledge. What do you do with it? Okay, so you are able to access it. It is predominantly de-identified, but at times it is identified. If there is a leak, or this material gets into the wrong hands, it can be potentially incredibly damaging for individuals within our society, or systems and processes in place. So remembering that you're dealing with personal information on big scales, and the security systems that are in place are incredibly important when dealing with big data. Also, ownership. Who really owns that information? Do I own that information? It's my information about my health and my outcomes. Do I want someone else knowing that information apart from me and my doctor, which is supposed to be doctor-patient confidentiality? If someone's coming in, a third party's coming in to use that data, do I really want them knowing that data? So it's something to be mindful of when you're working in this field from a public health perspective. It's important to have this data for all those reasons we talked about, but it's also important to look at it from an ethical standpoint. Are you able to obtain that data from an ethical point of view? Do you have permission? Would you be providing an opportunity for patients who have provided that information to give their authority for that use? If not, how are you going to be using it? How are you going to be publishing it? Mindful that it is sensitive information. And quality assurance. Are all those data points in that data set correct? There's a huge amount of data. There's sure to be faults at some point in time. So it's important to keep control over these big data sets as well, in terms of data cleaning and ensuring that your input of data from the, whichever registries it may be, have systems in place for quality assurance and quality control as well. It's no good bringing in a policy or an intervention on false information, or information that may not be as it seems. Another big limitation is that big data can often provide a fragmented picture. Okay, so it does interconnect things and does interconnect the patient in terms of different disciplines and health access and movement across the globe, but it still can be quite a fragmented picture of just their access to the health service, or just their access with the biomedical world, or doesn't really delve into those determinants. Why is that person there in the first place? Why are they experiencing it? It is still quite a siloed picture of that person's trajectory, or that path within the health system. So it's important to take big data for all its benefits, but also look at ways we can provide those gaps. Fill in the grey areas in the black and white. So there's still very much a need for public health information to be collected through qualitative means. What other RCTs or quantitative data collected, or observation studies, case control studies, all those other forms of research within public health are still important in this world of big data. It definitely provide an opportunity for us to strengthen our capacity as public health practitioners, but we have to remember that it's still only pieces of the puzzle, and there's going to be a need for other methods to fill that whole picture. So in the future, like I said, we're really going to need to look at quality of data and a means for controlling the quality of data, particularly in terms of drug-resistant infections and all these sorts of things. We need to know that what we're doing has got quality data surrounding the monitoring within a public health sphere. It's also important to look at this to not only monitor and manage, say, infection outbreaks or global epidemics, but also look at it for public and preventative health, monitoring chronic disease, monitoring disease trends, monitoring causation within these disease trends. But like I said, we have to remember that big data and monitoring these trends is only one piece of the puzzle. We also have to remember that we have to look at the instruments that we're using. How is these data points being collected? Is it being fed through mandatory reporting systems in hospitals, or is it survey-fed instruments from patients that enter within the healthcare system? And it's mindful of that when you're looking at the data as well. So basically, the limit of big data is that there often is not an actual causal explanation behind the data points. There might be explanation for an association, but why it is happening and the reason for those populations from a more sociological standpoint is unexplainable with this data point. So we need to bear in mind that we need to pair it with these qualitative methods to really find solutions to emerging public health issues. And there is a need for rigorous governance and quality control with all that data collected, and then an understanding of the ethics of its use. That's all from me today. I look forward to talking to you next week. Thank you.